Hello, I'm Younossi. I'm the professor and chairman of the Department of Medicine at the Nova Fairfax Hospital in Falls Church, Virginia, in the United States, which is right outside Washington, D.C. Let me first thank the organizers for allowing me to make this presentation about the impact of hepatitis C infection on patient-reported outcome, work productivity, and both direct and indirect cost of care. What I'll do over the next 15 minutes is to define some terms, and then we can show you some data. So let me first define what patient-reported outcomes are. Patient-reported outcomes are part of the spectrum of outcomes that include clinician-reported outcome, physiologic outcome, those that are reported by caregivers. The clinician-reported outcomes are those things such as hepatitis C RNA that's reported on a blood test by a lab. Physiologic outcomes are those that are really physiologic, such as a hemoglobin A1C. And then, of course, patient-reported outcomes are really defined as measurements that are based on a report that directly comes from the patient without any changes or amendment or interpretation by anyone else. PROs, or patient-reported outcomes, really is an umbrella term that includes a number of things, including health-related quality of life, patient satisfaction, compliance, and other things. And we are measuring PROs because we want to capture the comprehensive impact of a chronic disease such as hepatitis C. So, for example, the clinical outcomes are really, for example, liver fibrosis or cirrhosis. They're a surrogate of survival. On the other hand, PROs are the surrogate for patient experience, while economic outcomes are surrogate for resource utilization. Now, you can't really directly see PROs or measure them, so you have to measure them indirectly using a number of instruments or questionnaires. So an example here is health-related quality of life. You measure different aspects of health-related quality of life related to different domains: social domain, psychological domain, and physical domain. And each domain is measured through a number of items or questions. And of course, you score each one of these areas in a way that will represent that domain as a summary score for each one of these areas or constructs. And there are PRO instruments that will give you domain scores as well as overall scores. Now, another important concept in assessment of the comprehensive outcome of hepatitis C is to measure work productivity. And of course, you can measure work productivity in a number of different ways through questionnaires that are filled and completed by patients, and that could be a form of PROs. But work productivity is really defined as the economic productivity of workplace, and it measures the productivity at workplace that's directly affected by illness or its treatment. Now, work productivity can be divided in two different sort of categories. Absenteeism is really related to the absence at work, related to health-related sort of issues, and then presenteeism means they really reduced performance. So that means that you're at work but you're not performing optimally. And the presenteeism and absenteeism are the two measures of work productivity that's been traditionally measured. In hepatitis C, you have a really different sort of component of the disease that can impact PROs. So some are related to the disease and to the individuals, related like comorbidities, but also hepatitis C infection can have a negative impact on PROs. On the other hand, treatment can have either a positive impact or a negative impact. So in the old days, interferon could have a terrible impact on patient-reported outcome, while as I'll show you the data, you can have the new treatment without interferon or ribavirin that can have a positive impact. And of course, if you achieve sustained virologic response, as I'll show you the data, there will be some improvement of PROs. Let's just look at some historical sort of data. This is actually a slide showing the health-related quality of life of patients with hepatitis C as compared to healthy controls using an instrument called SF36, which is a generic instrument. And all you see here with these bar graphs are the domains of SF36, and this is a difference in domain as compared to the healthy controls. The bottom line is that when you look at all of these domains, there is actually at least a 5% or more decline or difference between the quality of life of patients with hepatitis C as compared to controls. So there's an impairment of health-related quality of life in patients with hepatitis C that's inherent to this infection. Another aspect, of course, as we mentioned, is the work productivity and productivity and activity index, which measures work productivity. Here, as you can see, the most important aspect of the infection as impact on work productivity is a decrease in presenteeism, as well as overall work productivity impairment, as you can see here. Now let's look at some regimens that can capture the impact of treatment of hepatitis C. So here is data that was published a few years ago, looking at two kinds of treatment. One in red that includes interferon and ribavirin, and the blue just includes ribavirin. The bottom line of this slide is that, and of course here the quality of life was measured by generic SF-36, and you have two summary scores. That, as you can see in the red lines, there is a rapid decline of quality of life, both in mental health and physical health, once you start interferon, and that remains very low and comes back up once you stop the treatment. When you get rid of interferon, but you still have ribavirin in the regimen, then you have a mild decline, a reversible decline in quality of life, specifically in the mental health aspect that actually recovers after treatment. Here is another study that was published about 3 years ago, looking at now interferon-free and ribavirin-free regimen, and the instrument here is CLDQ HCV, which is a disease-specific instrument. And as you can see in this sort of a lighter shade of pink up here, is that this is the regimen that does not include interferon or ribavirin. And in fact, after 2 weeks of treatment, you see an increase in quality of life of patients that are treated in this regimen. However, more darker shade line suggests that there is actually there's not a significant change after 2 weeks in terms of PROs. And of course, this is probably related to the use of ribavirin. Once you stop ribavirin, then the quality of life goes up to very similar to the other regimen. And of course, one question is, this was not blinded studies. If you have placebo, what happens to placebo? This is another study looking at the all oral regimen that does not have interferon ribavirin as compared to placebo in gray lines here. The placebo really did not show any change, while the active treatment showed significant improvement during treatment and after treatment. And this can actually also be seen in patients with more advanced liver disease. This is the data from Astral 4. And again, the same things happens. Patients with advanced liver disease, they also get improvement of their PROs. And actually, patients who have decompensated liver disease, they get even more improvement of their PROs. Work productivity, again, when you look at work productivity, the only difference here is that the lines going down suggest improvement. So a lower score for this instrument, WPAI, suggests better work productivity. And again, the same things you see with the different regimens, that there is actually an improvement of work productivity, primarily on the absenteeism side, primarily on the presenteeism side of work productivity that's improved after treatment, and some actually even during treatment. Now let me look into PRO changes as a consequence of sustained virologic response. And again, you have summary of a number of different studies here and different instruments, SF-36 in blue here, FACIT-HIF, which actually measures fatigue. You have a disease-specific instrument and work productivity. There are a number of different regimens, as you can see here, and as you can see, and this is actually multiple different domains, and this is a different domain from the baseline. So a bar graph that goes on the positive side suggests improvement of PROs. And as you can see, with all of these regimens, sustained virologic response is, generally speaking, associated with significant improvement of different aspects of quality of life. Of course, one issue has been the sustainability of the PROs that you see after SVR. This is a registry, and as you can see, with multiple different domains, and that followed up to 144 144 weeks of follow-up, that after entering into the registry, there is improvement. This improvement actually continues over time, and actually maybe in some areas even improve. And you can also see this improvement in sustainability and PRO improvement even in patients who have cirrhosis. Now, if there is significant decompensated cirrhosis, there may be some improvement, but just because liver disease is at that point quite compromised, the improvement may not continue to get better over time. Now, we've also looked at the PROs in a number of different patient populations. Here's a study that was published in Journal of Hepatology, and we looked at patients who have minimal fibrosis or advanced fibrosis. And as you can see in the green, that the improvement in minimal fibrosis was as good as those patients with advanced fibrosis. Another study just published just a few months ago, looking at patients who did not have any fibrosis or minimal fibrosis. And just to summarize all of this, there is actually improvement even in patients with minimal fibrosis, suggesting that you don't need to have advanced liver disease to actually gain the benefit of PRO improvement or patient experience. Looking at patients who are on opioid substitution therapy, this is another cohort that has been on high risk, and again, you see that these patients also have significant improvement of patient-reported outcome during treatment after sustained virologic response. Children, the same sort of data. Here you can see the two studies of the HIV, HCV co-infected individuals. And if you look at Astral 5 data over here, there is significant improvement of PROs in patients who are co-infected. In fact, we all now treat patients who are co-infected the same exact way as mono-infected individuals, and that can also be supported by the PRO data. Finally, we looked at different part of the world in terms of PROs for French patients with hepatitis C. This was also recently published. Again, the same thing happens here. And even when you look at East Asian patients who are treated with these regimens, there is actually a significant gain in PROs. So to summarize this part of my talk is that PROs and work productivity are important components of the comprehensive outcome assessment in hepatitis C. PRO and work productivity of HCV-infected patients are impaired. And these PROs actually improve during treatment with interferon and ribavirin-free regimens. And most components of PROs and work productivity also improve after achieving sustained virologic response, which we consider cured these days. These improvement in PROs are really durable. They're sustainable at least up to 144 weeks of follow-up that we've had, and we're going to have up to 5 years of follow-up in the future that we're going to report. And the PRO gains are really applicable to all patient populations that we have studied. Now let me turn into the second part of the talk, is to really talk about economic outcomes of hepatitis C. And as you know, there are different analyses that's been done to assess the economic impact of hepatitis C and its treatment. Budget impact of treatment, there's cost effectiveness, and then the economic burden of disease. I'm just going to focus primarily on the direct economic burden of hepatitis C. This data came from the United States. It looked at 2011. As you can see, because of the baby boomer, the expectation was to actually have a significant rise in the cost associated with liver disease of hepatitis C in the United States. And that was estimated for 2011 to be about $6.5 billion. Of course, as you go to more advanced liver disease, for example, patients who have end-stage liver disease of cirrhosis, HCC, or even requiring liver transplantation, the cost will go up substantially. There is also an important issue that hepatitis C is not just a liver disease, it's a systemic disease that has a number of other extrahepatic manifestations. This is a meta-analysis that we published a few years ago looking at extrahepatic manifestations of hepatitis C and the costs associated with this. And as you can see here, this looked at things like mixed cryoglobulinemia, lymphoma, diabetes, depression, porphyric cutaneous thyroid, and other complications. And the cost for the United States was estimated to be about $1.5 billion per year. This was also replicated in another study that Dr. Kakub and I were a part of, looking at 5 countries, including UK, France, Germany, Spain, and Italy. And the cost of extrahepatic manifestation in EU5 was estimated to be about 2.1 billion euros. Another way to look at the indirect cost of hepatitis C is to look at cost of work productivity loss. due to an infection. These are two papers that we published about 3 years ago, looking at the cost associated with productivity loss in the United States. That was estimated to be about $7.1 billion every year, and then EU5 countries that are the same as the one that we just talked about. This was an additional 2.6 billion euros. So work productivity loss can actually significantly have a significant negative economic impact. We replicated the same study in East Asia, Taiwan, South Korea, Hong Kong, and Singapore. And this is the data that was published last year in Journal of Viral Hepatitis. Again, in these 4 Asian countries, about $500 million annual cost related to work productivity. Another important issue is to see if there is economic benefit of SVR. And there are a number of ways that you can look at. Of course, everyone is focused on cost effectiveness. And when you look at cost effectiveness of most of the studies that looked at different regimens, they looked at on liver outcomes primarily. And most of these studies that summarized here on the slide suggest that, at least in the United States, the treatment that we currently have is cost effective. Of course, the cost effectiveness of any regimen will depend on the cost of the drug and also willingness to pay threshold, which could be different from one country to another country. In general, there are different rules for willingness to pay or ICER thresholds. It could be somewhere between 3 to 5 times the GDP of any country. So in the United States, traditionally the willingness to pay threshold was about 50,000, but one can argue that that's too low and it's too outdated and could be as high as 150,000 per life saved. But that does not apply to the other parts of the world, and the data from the rest of the world needs to be looked at on a country-by-country basis. Now, is a treatment of the extrahepatic manifestation of hepatitis C also cost-effective? And here is a study that was published a couple of years ago, looking at basically if you have milder disease, F0, F1, and F2, and you're looking at the non-liver outcomes, meaning that a % reduction in non-liver related mortality, how do you actually, how the cost effectiveness of these regimens look like? And as you can see, even if there is a modest reduction in liver-related and non-liver related mortality in these patients, that most of these regimens remain cost effective. So this actually is an argument that patients who have mild disease but have extrahepatic manifestation, they should receive treatment. Again, another study by Dr. Patrice Coupe and the rest of our collaborators, looking at, again, the same study that he showed in terms of cost of extrahepatic manifestation, what is the cost of cure, and as you can see in the bottom line, the substantial savings that happens related to extrahepatic manifestation after HCV RNA eradication or SVR. Finally, one way to look at cost effectiveness of a regimen, or at least economic impact of a regimen, is to see if even if you're not going to change the mortality, can you actually reduce cost related to complication of cirrhosis such as hepatocellular carcinoma and decompensated cirrhosis. We looked at the data from Japan just because HCC is a major cause of cancer in Japan, and most of the Japanese patients with hepatitis C are infected with the genotype 1b. And we assume that we basically will use the treatment that are currently approved in Japan for treatment of hepatitis C, and all the rates for the efficacy came from randomized clinical trial. The cost data came from Japan. Willingness to pay was what has been accepted, which is between 4 to 6 million yen. And when you look at the comparison to no treatment, you'll see that there's a significant number of cases of HCC avoided. There is actually also qualities that are gained, and that actually translate to a significant amount of per patient cost of both HCC, decompensated cirrhosis, as well as costs of complications that are actually avoided, leading to a substantial improvement in economic burden in patients with hepatitis C in Japan by just reducing HCC and decompensated cirrhosis. Finally, what happens in terms of treatment and cure in terms of work productivity? I showed you the data in terms of the negative impact of hepatitis C infection on work productivity. Here is data from the United States and also EU5 that by curing hepatitis C patient with all-oral regimen, you can actually have an annual saving of 2.7 billion in the United States and another €500 million in EU5 countries just due to improvement in work productivity. This was again replicated in a study from Japan, and again a number of these countries looked at: Hong Kong, Singapore, South Korea, and Taiwan. And again, in each country, the significant improvement in economic burden of hepatitis C due to improvement in work productivity. Finally, let's just summarize this in terms of a study that we looked at value of cure. And value of cure, of course, looks at not only the cost of treatment, but also the outcomes. And the outcomes is not only improvement in terms of mortality, but also improvement in terms of quality of life. We model this using HCV genotype 1 in patients with hepatitis C in the United States, and we use a Markov model. 1.1 million treatment-naive hepatitis C patients were estimated to exist in 2015 in the United States, and we compared regimens that were approved and only focus on genotype 1 patients. And when you look at this, there is actually about 2.9 million more QALYs gained by treating these patients, and even using the thresholds or the willingness to pay of 50,000, there was significant savings of 144 billion. But if you go to up to 150,000 willingness to pay, this could be as high as $430 billion. And of course, you take into consideration the cost of these regimens. The value of cure is that the United States will have about $51 to $350 billion savings by treating hepatitis C genotype 1 patients. And this brings in value to the society. So let me summarize my talk to just present to you that the economic impact of hepatitis C is related to its clinical, but also patient-reported and work productivity outcomes. Hepatitis C cure with highly effective all-oral DEAs can lead to both clinical, PRO, and economic gains. The economic gains are related to both direct and indirect savings. The value of cure can be recognized only if the impact of SVR on the comprehensive hepatitis C outcomes are considered. And in this context, the comprehensive approach to demonstrate the value of HCV cure must be consistently and repeatedly communicated with policymakers in each country. Well, thank you very much for listening. And again, I appreciate the opportunity to present to you. And of course, I'll be available for any questions that may arise. Thank you.